Hi, my name is Dr. Ross Hauser. Welcome to the Hauser Neck Center here in Fort Myers, Florida. There's a condition that we diagnose quite frequently on the clients or patients that come here, and it's called Mal de Debarquement Syndrome. Patients will come in with like a rocking sensation. They feel like there's almost like a dizziness and a weird sensation that they can't even vocalize. So I'll just ask them, hey, you know, like when you're on a boat for a long period of time and then you get a little bit seasick, or you then get on land after you've been on the boat and you just feel like, you know, like things are just rocking a little bit, that is normally Mal de Debarquement Syndrome. And part of this talk is I'm not as concerned about diagnoses as I am etiology. And I think this is important for everybody to realize. If I was going to give the government, and they're not asking for my opinion, but if I was going to give the various governments of the world, they were trying to ask opinions of how to get healthcare costs down, I would say that we got to get away from so much emphasis on you have vestibular migraine, or you have Meniere's disease, or you have Mal de Debarquements, and we got to get more and more involved in etiologies. Like, we have to have more conversations about the etiologies of what's causing the symptom, because you're going to see that how, you know, like, yeah, there might be fine points in what constitutes a vestibular migraine and what constitutes Meniere's disease and what constitutes Mal de Debarquement syndrome, but really what's important is what is the etiology of it, like what's causing it, and then is there something simple the person can do? Give you an example. These are just a couple cases that come to mind. Like, a person comes in, they got the rocking sensation, They had a CT scan of the temporal bones, which showed semicircular canal dehiscence. And for anybody who wants to learn about that, please see the video that I made. I made like a 1-hour video on semicircular canal dehiscence. So the semicircular canals, which we'll see, is how your body regulates balance. So dehiscence means the bone that it's in has dehisced, or there's now little bites out of it, or little places where it doesn't exist anymore. So I asked the person, well, what side was it? And they said the left side. Well, guess what we found when we did the jugular vein studies in the office here? They had a block way worse on the left side than the right side. Okay, so let's go back 1.5 hours. So if we went back, if you saw me 1.5 hours ago, so I have a new client, so it's a new client from Wyoming, and I'm taking their history, and it's that same thing. It's like the number one thing that my staff had written down was dizziness. So we're going to go through different kinds of dizziness, and I'm like, can you tell me about it? Can you do it? And again, the person's like, it's just hard to explain. You know, it's not quite a spinny thing. It's not quite a rocking thing. Then I said, well, is it like you're on a boat, then you get off of the boat? And the person said, sort of. You know, it's just very hard to clarify it. But the interesting thing was, so I'm taking the history, then, and this is kind of another key point, is do you have any ear fullness, or are you losing any hearing on one side of the body or the other? And the person said, oh, for sure, I'm losing so much hearing on my right ear. Okay. And you might say, come on, doc, what does that have to do with the dizziness? Well, cranial nerve 8 is the vestibulocochlear nerve, and this is what I explained to the person. It's the vestibulocochlear nerve. The vestibular nerve is what brings your balance. You know, when the semicircular canals say, hey, Ross's head is tilted to the left, the right vestibular cochlear nerve and the left vestibular cochlear nerve take the impulses from the semicircular canals to the brain, different parts like the cerebellum and different other parts, Because in other words, I might have done too far. Now I'm losing my balance. So the brain will figure out what to do so I can get my balance back. But it's called the vestibular cochlear nerve because there's a second component. The vestibular part's the balance. The cochlea, cochlear implants is for hearing. So the cochlear part is hearing. So in other words, if you have imbalance, but you're like, no, I have primarily ear fullness on my right, or I'm losing hearing on my right. So me as a physician who's trying to figure out not diagnosis, but etiology, you see, like in other words, is it a right-sided problem? Is it a left-sided problem? This person, it was on the right side. So I'm like, before I even looked at the thing, we're going to find right jugular vein compression. And when it was all said and done, I'm like, yep, you have an 85% compression of the jugular vein on the right side. You have like a 60% compression on the left. Then she admitted to me that, yeah, I'm just now starting to lose hearing on my left side. So the treatment then is what? We just got to figure out what's causing the jugular vein compression, then what should get better. The rocking sensation should get better, and then of course the hearing should get better. I'm going to go through some diagnoses, but to me they're not so crucial. What's crucial is understanding the principle of it, and then what is the etiology of why the person's dizzy or why they have a rocking sensation. So Mal de Debarquement Syndrome is known to be a cause of feeling off balance. It is characterized by a feeling of rocking and swaying and typically follows prolonged exposure to motion, such as being on a boat or a plane. There's an illusionary rocking motion. Now, they say nausea is not a prominent symptom. So does it mean that if you have this rocking sensation and you have nausea that you don't have Mal de Debarquement's? No, because the same process, the breakdown of the cervical curve that is obstructing the jugular vein, it can injure your vagus nerve. So guess what you get when your vagus nerve is injured? You get a lot of nausea. You can get nausea because the stomach isn't working so good. And then because the jugular vein is blocked and your brain pressure gets high, guess what? Intracranial hypertension can cause nausea. So you see where people may not get this diagnosis for a doctor who's like, no, you have nausea, so you don't have Mal de Debarquement's. You could have 2 or 3 different diagnoses, right? You could have gastroparesis, your stomach isn't working because of vagus nerve degeneration, or you have intracranial hypertension, and that's causing the nausea, right? So then they don't diagnose you with Mal de Debarquement's. But the more important thing is the etiology is the gastroparesis, the intracranial hypertension, the Meniere's disease, the Mal de Debarquement's. It can all be because of ligamentous cervical instability and cervical dysstructure causing a breakdown of the neck curve, blocking the jugular veins, injuring the vagus. So again, it's more important the etiology. And Caring Medical and the Hauser Neck Center, we're very, very good at etiology. Like, we want to get at the correct etiology of what's causing a symptom like Mal de Debarquement's, because once we got the right etiology, then we figure out a plan, whether it involves prolotherapy, curve correction, sleeping in a certain position, various exercises to unblock the jugular vein and get the vagus nerve back. So you could see, like, there's anxiety-related dizziness, vestibular, migraine. What's interesting about this is, see where it says response to medication. Some doctors said, oh, you got Meniere's disease, so I'm going to give you Antivert, and it didn't help. Or you had another doctor say you might have migraines or vestibular migraines or vestibulopathy, and they gave you migraine medication, it didn't help. Or you got anxiety medication, it didn't help. You probably have Mal de Debarquement syndrome. You probably have Mal de Debarquement syndrome. And these, again, there's all different kinds of things: persistent postural perceptual dizziness, non-motion triggered motion moderated oscillating vertigo, oscillopsia, semicircular canal dehiscence. We could come up with 20 different diagnoses that cause dizziness, and I'm just saying the more important thing is what is the etiology, because they all can have the etiology of ligamentous cervical instability. And again, here's some more vestibular or balance issues that occur after trauma, again, there's more and more diagnoses: perilymphatic fistula, vestibular nerve injury. So, okay, so you have the ear here. Here's the ear canal. That's where you get ear wax. You have the tympanic membrane. These are the semicircular canals. That's the cochlea. Then there's going to be a nerve that goes to various parts of the brain to interpret what's going on here. So in other words, when you turn your head, the fluid in here is going to change. The fluid distribution is going to be different in the semicircular canals of the left side and the right side. That goes to the brain and says, hey, the head's, Ross Hauser's head's turned to the left and it's down, you know, if it's interpreted correctly. So imagine if the nerve impulse was incorrect, the right side versus the left side. So say somebody had jugular vein compression on the right, which was causing increased fluid pressure on the vestibulocochlear nerve on the right. So in other words, the left one was working right, so the brain's getting the right information on the left side, but it's getting the wrong information on the right side. So it's getting the wrong information, so you can understand where the brain's going to interpret it that the body's rocking, you know, because you have, in other words, it's changing because the nerve impulse is dysfunctional, basically. Okay. And then this is like what it looks like inside. So inside the semicircular canals, it's like a tube that's encased in bone, and the bone is the temporal bone. So on the new patient, I did order a CT of the temporal bone to look at semicircular canal dehiscence. In other words, is the fluid pressure so high here, especially on the right side versus the left side, that it's been so, because, you know, again, people come in because they've had the problem for years. So in other words, there's probably been a block for years. So the CT scan of the temporal bone can tell, yeah, the bone is denuded or it's dehisced, so the person has semicircular canal dehiscence. Then it can also show whether there's a hydrops, like there's a block, and there are surgical procedures that a person can get. I've never had to have a patient need those surgical procedures, but it'd be good for them to know if there is a surgical procedure, because then the person can make a good decision about what to do, whether to do the jugular vein stuff to unblock it to see if it gets better. And again, basically, when there's a block, you can get all kinds of obstructions, and in Meniere's disease, there's a thing known as Endolymph hydrops, where one of the semicircular canals, there's just a lot of fluid accumulation. And then, yeah, this kind of just shows it, like, see how there's excessive fluid right here. So again, when there's, let me just say this. In the semicircular canals, if the fluid pressures aren't right, like let's just say there's too much fluid pressure here, the brain isn't going to interpret the body position correctly, you know, and then you're going to get like a swaying or a dizziness. So this is semicircular canal dehiscence. You can get fistulas. Yeah. Okay. I love this one. So I love this thing. So this is the jaw, right? So you know, you can, you know, the mandibular condyle here, and look at how close the jugular vein is to it. And then look at how close the semicircular canals and the cochlea is. So this is the jaw, so it's right here. So this is my mandibular condyle for Ross Hauser is right here. So this is my earlobe. Well, guess what if I just go right here? So my mandibular condyle's here and my atlas is right here. So the C1's right here. So there can be times where the position of the jaw is part of the problem. So the lady from Wyoming, it turned out when her tongue was on the roof of her mouth, the jaw went forward and her jugular vein opened up like 30 to 50%. So that was one of the recommendations that I had for her. And then believe it or not, TMJ problems. There's a ligament called Pinto's ligament. So if you go on Google and you type in Pinto's ligament, and I have a little bit of this. So I have a little bit of this. My jugular veins are open, but because I still have a little bit of bruxism. So bruxism is in the middle of the night, you're clenching your teeth. So it's clenching your teeth in the middle of the night. It's way, way better than it used to be. So probably my amount of clenching is probably down by, 90% or so. But there just are times where life throws you some curveballs. And now in my life, I actually have some curveballs going on. There's some significant health problems in my family. So probably, I got a little bit of my bruxism. So there's going to be days where I'll wake up in the morning and I'm just like, I got ear fullness in my right ear. I didn't have it when I went to bed, and now I got ear fullness. Now I don't quite have the rocking, but there definitely are times where I could just tell I'm a smidgen dizzy. So basically, what I need to just do is get my eustachian tube open. So I just take a Q-tip or my finger, and then the thing drains, and then the dizziness and the lightheadedness, it goes away. So I never had Mal de Debarquement, but you could see where if it was happening every night, that could happen. So it's easy. Can you see where it'd be easy if there's a block right here at the atlas and there's fluid accumulation here, where one of the first things that's going to be affected is the cochlea, which is hearing. And I would say if you're starting to lose hearing or you have ear fullness, you should consider getting evaluated. Is there an internal jugular vein block, and obviously balance. So this is just kind of some of the things it looks like. This is a CT venogram. So CT venogram, you could see where there's compression right here. There's compression. And then, of course, there's various procedures. What we do is we do cervical curve correction prolotherapy to open up this. Occasionally it's from an elongated styloid. Some people have to get their styloids removed. And then there's MRI. You can do MRIs too to show vestibular and cochleal endolymphatic hydrop. So it just means that there's a block of the fluid in the semicircular canals. And then this is just something that we made up. Meniere's disease, Mal de Debarquement, all these various vestibulopathy, they have all kinds of different symptoms. Well, those same symptoms can come from ligamentous cervical instability. So if you're at home and you're like, I've never heard this before, the thing to consider is, do you have neck pain? You have like a tension that won't go away in your neck. Do you have head pressure? And do you have clicking, popping, grinding of the neck? Like my neck doesn't click and pop. It's not normal to move your neck and have clicking, popping, grinding. So if you have clicking, popping, grinding, you got some ligamentous cervical instability. And anybody knows that when you have a cabinet door and it's jingly a little bit when you open and close it, like the hinge is loose. Is it a hinge problem or is it a screw problem? Like it's a screw problem. You get out the screwdriver, you tighten the little screws on the door handle, and then the thing's cured. So in other words, your neck's not supposed to click, crack, pop, and then the muscle tension is the muscles trying to stabilize the vertebrae because you have ligamentous damage. Ligaments are what hold the bones together. So when there's ligament damage, the most common cause of ligament damage nowadays is the many, many hours people spend looking at a cell phone, because when you look at a cell phone for hours and hours and hours, or you have terrible posture when you're doing computer work, it stretches the ligaments. It stretches the ligaments. And the problem is ligaments are white. They're not red. Muscles are red, ligaments are white. So when a white structure like the labrum, like a tendon, like a ligament, they don't have as good a repairability as a muscle that's red. So once you stretch out a ligament, or you have a concussion, or you knock your head, or you get too strong of a manipulation from a chiropractor, or you self-manipulate. The problem is once that ligament is incompetent, it's incompetent for the rest of your life unless you get prolotherapy. But eventually your body's going to do what? Overgrow bone there, right? So that's in other words, the body's response to an injured ligament is to tighten the ligaments to try to stabilize the area or swell the joint, right? You have chronic knee swelling. Well, the chronic knee swelling is the body's trying to stabilize it because you got ligament damage, you need prolotherapy. Same thing in the neck. If you got ligament damage, the joints get swollen, the muscles get tense, and eventually you get the overgrowth of bone, which is called arthritis. So normal versus abnormal. So what happens is with certain neck motions, there's certain fluid distribution things that happen in the semicircular canal. When you have obstruction of the jugular veins, the fluid distribution in the semicircular canals is going to be off. So your brain, your cerebellum, and different parts of your brain are getting the wrong information. So even though you're not moving, it's as if you're moving. And this is just another illustration about ear and hearing disorders and all the different things that can occur when the jugular vein gets blocked. And you can hear sounds that aren't there. You can get sound sensitivity. Too much earwax can be formed, dizziness, Mal de Debarquements, clicking sounds. I had a patient recently, they're like, "Doc, I'm just telling you, it's like click, 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 click," because they have a tensor tympani myoclonus, again, because the jugular veins are blocked, and then there's irritation of a nerve, and then the muscle in the inner ear, it keeps contracting. You can get altered sound perception, ringing of the ears, ear fullness, loss of hearing, all kinds of gaze instability. So one of the tests that we do in the office here is for gaze stability. We'll have, on a computer screen, we'll have somebody look at a stationary object and, like in other words, are they able to do that? Then we'll have where the light goes from here to here to here to here, and then the infrared is measuring, is the eyes coordinated? And then we'll have it where they have to follow the light. You have to follow the light. So all these things tell is their gaze instability. So the same process that causes Mal de Debarquements can cause gaze instability, because basically there's ligament damage in the neck, so the neck proprioceptors tell the brain what's going on with the neck. Those are off. And then there's many cranial nerve dysfunctions that occur with jugular vein compression, not just the vestibulocochlear nerve, but also the optic nerve or the eye nerve. And then basically when you test various reflexes, so the optokinetic reflex, the cervical ocular reflex, and the vestibulocular reflex, these are all reflexes like when you move your head, your eyes have to go in a certain way, and there's a lot of coordination that occurs. When you get jugular vein compression, all these things can be affected. And I'll talk a little bit more about them later in the talk. So this just shows that you basically have jugular vein compression, or you have instability that's blocking the cerebral spinal fluid. The cerebral spinal fluid getting blocked can put pressure on the brainstem, so the balance centers in different parts of the brain can be affected, and you can get all kinds of different symptoms: swallowing difficulty, abnormal eye movements. The patient from Wyoming, they said when they looked to the right, they would get double vision, like when they look to the right. In other words, on the right side, one of the eye nerves, whether it's cranial nerve 3, 4, or 6 that move the eye, so the eye nerve on the right side wasn't working right. Again, okay, so the eye nerve isn't working right, the vestibular system on the right isn't working, they can't hear on the right. Do they have 3 or 4 different conditions, or it's just one condition, which is a blocked jugular vein on the right? That's what I said, we need to have the right etiology. So the most important thing, when you have a symptom, a chronic disease, is what is the etiology, right? Doctors are very good at making diagnoses. They're not so good sometimes about what's causing it, because to resolve it, you need to have the right cause. So this is very, very interesting. Some of the potential ways that ligamentous cervical instability can lead to vestibulopathy, Meniere's disease, Mal de Debarquement, vestibular migraines, and a host of them. You get ligamentous cervical instability, blocks the jugular vein. Then there's fluid flow obstructions for the semicircular canal causing endolymph hydrops. This leads to improper balance information being transmitted to the vestibular cochlear nerve to the cerebellum, and you get all kinds of symptoms. I feel like I'm falling over. When they're in a car and there's fast-moving objects, the symptoms can be worse. They have decreased fine motor movements, lightheadedness, postural issues, spinning sensation. Now, occasionally it's because of crystals, so people will do Apley maneuvers. They'll go to a physical therapist who will do these Apley maneuvers, and they have a dramatic recovery. I often see people where this just didn't work, so I very seldom have patients where that works. This is just more, this is one of our patients who had a lot of dizziness. See how the C1 is obstructing the jugular? So the semicircular canals are right here. This is the jugular bulb, internal jugular vein getting obstructed here. Can you see it there? Like it's almost like it's getting choked. That's what often causes Mal de Debarquement's, Meniere's disease, dizziness. This is just an overview of how ligamentous cervical instability can cause eustachian tube dysfunction, dizziness, impaired neck proprioception, dizziness, postural orthostatic tachycardia, dizziness, vagopathy, dizziness, tension on the brainstem, dizziness, all different kinds of mechanisms by which ligamentous cervical instability causes dizziness. And these are all the mechanisms by which cervical instability can lead to dizziness or Mal de Debarquement. And then ligament injury of the neck, eventually the muscles, the ligament muscular reflex, the muscles will tighten up. So that's where you can't get enough massages, like nothing relieves it. So if you have a chronic low back pain, chronic neck pain, and it won't go away, it's probably because the muscles are protecting you because of underlying ligament damage. So you got to get that ligament damage checked out. And what happens is, this is a normal curve. When you have a normal cervical curve, the jugular vein and the vagus nerve are in their relaxed position. Once you have a reversal of the curve, so you see the difference between this is the normal cervical curve, bad curve, the atlas is so far forward, then you get obstruction of the jugular vein and you get pressure in the vagus. And this is right where a lot of the vagus DNA is. So if you research nodose ganglion of the vagus, which is the most important ganglion. Ganglion is where the DNA of the cells are. It sits right in front of the atlas at C1. So the vagus nerve has 100,000 nerve cells. And if you got pressure right where the DNA is, obviously the nerve cells are going to die. When the nerve cells die, instead of the vagus being this big, it gets this big. And that's kind of what we measure in the office. Then when we correct the cervical curve and it gets stable with prolotherapy and the pressure goes off of the vagus, then we see the vagus, instead of being this big, it gets bigger and bigger, and hopefully until it's normal, and then the function is normal. This is just another thing about how ligamentous cervical instability, internal jugular vein compression can lead to like ear problems, or the acoustic reflex, which is how a person dampens sound when sound's too high. So again, there's lots of different symptoms that patients have. Often they can be attributed to one etiology, which is like internal jugular vein compression. And then basically what happens is, when you have ligamentous cervical instability, you can get nystagmus, where the eyes are going like that, dizziness, vertigo, oscillopsia, where there's a swaying like Mal de Debarquement's. You can get blurry vision. You can get poor balance. And then when you're tested, right, can your eye gaze stabilize during head motion? So in other words, in the office, if we wanted to, we normally don't do this, but I could literally have a person take that test that I said for gaze stability, but I have them doing it like watching the dot while they're moving their head. So the cervical ocular reflexes, eyes move in relation to neck rotation. So you don't, like if I'm looking at you and I rotate my head, my eyes have to go to the right, right? So all these things get off when you have ligamentous cervical instability. And then these can lead to all this. And then if you research like whiplash injuries and all the symptoms that you get after a whiplash injury or concussion, you'll see that a lot of these reflexes are off. And I'm just saying I think they're off because the person got ligament damage from the concussion or from the whiplash. But the number one cause of ligament damage now, I think it's just plain old slouching with a cell phone. So just be careful, don't slouch, try to have your computer screen up, and always be using your neck muscles. Now, the normal treatment for a lot of this is called vestibular therapy or visual therapy. So there's physical therapists that do a great job with balance. It definitely helps a lot. Often, to me, it's not, in a lot of cases, just not curative because you're not correcting the underlying cervical problem. And then this was just a study that was published where it was frequency of dizziness in patients with craniocervical instability before and 5 years after upper cervical fusion. So I just want to, you could see that by stabilizing the neck, a lot of the dizziness got better, right? Got better. And then I guess we're all done. So in summary, if you've been diagnosed with Meniere's, vestibular migraines, you have dizziness of unknown etiology, Mal de Debarquement Syndrome, consider that the diagnosis is correct, but the etiology is actually internal jugular vein compression. So doing tests, like we do ultrasound exams in different neck positions to document where and what's causing the internal jugular vein compression. Some people will do a CT venogram. That's normally just in one position, so it's helpful, but often you have to do motions in different neck positions. Then a CT of the temporal bone will help document whether or not there's semicircular canal dehiscence or endolymph hydrops. And then the treatment is, if there's a breakdown of the neck curve, which I call cervical dysstructure, then doing exercises and various things to restore the neck curve, that's very helpful. Sleeping in a position where the jugular veins are open. And then if there's ligamentous cervical instability, and you would know that you have that just by clicking, popping, grinding in the neck, or you have a lot of neck tension, then receiving prolotherapy is a good idea.